Welcome to The Deep Dive, the show where we really try and unravel complex medical conditions, pulling out those crucial insights you need to sharpen your clinical acumen and, well, navigate some challenging patient presentations.
Indeed.
Today, we're embarking on I think, truly immersive exploration of a condition that, despite its benign classification, consistently presents clinicians like yourselves with a formidable diagnostic puzzle and, frankly, equally complex therapeutic dilemmas. We're talking about Pigmented Villonodular Synovitis, PVNS.
That's right.
For you, our mid-senior medical professional listeners, getting to grips with the nuances of PVNS isn't just about expanding your knowledge base, is it? It's really about making a tangible difference in patient outcomes, often in cases that have perhaps baffled others for a long time.
Absolutely.
So to kick us off, perhaps you could explain what is the fundamental nature of PVNS and what is it that makes it such a perplexing condition for those of us in clinical practice?
Well, thank you. Pigmented Villonodular Synovitis, PVNS, is fundamentally a rare condition. It's benign, yes, but locally very aggressive. It's a proliferative disorder specifically affecting the synovium.
The joint lining.
Exactly, the joint lining. And it's crucial to understand that whilst it's considered a subtype of tenosynovial giant cell tumors, it's not actually a true neoplasm in the malignant sense.
Right.
But, and this is the key thing, its behavior can be remarkably aggressive locally. It can lead to significant and often irreversible joint damage if it's not identified and managed appropriately.
So how does that compare to normal synovium?
Well, think of the synovium in a healthy joint. It's a remarkably thin, quite delicate membrane. Its job is producing synovial fluid, that vital lubricant which allows our cartilage to glide smoothly, lets our joints move without friction. In PVNS, this normally delicate lining undergoes dramatic, uncontrolled proliferation. It thickens up immensely, overgrows into a dense mass, really, and produces an excessive amount of fluid.
So you get swelling.
Exactly. Significant swelling. And this accumulation, coupled with the sheer bulk of the proliferating tissue, resulting in considerable swelling, chronic pain, and ultimately a sort of relentless assault on the joint architecture itself.
And the long-term consequences.
The real long-term impact for patients is its potential for progressive joint destruction. We're talking about direct erosion of the articular cartilage, cystic remodeling, destruction of the underlying subchondral bone,
Wow.
and ultimately profound functional impairment and significant morbidity if the condition remains untreated.
And where do we typically see this?
Well, PVNS can manifest in virtually any joint, technically, but the knee is by far the most commonly affected. It accounts for up to 80% of all reported cases.
80%? That's high.
It is. But we also frequently encounter it in the hip, the ankle, the shoulder, and even the elbow. And depending on the joint involved, that often poses quite significant diagnostic challenges.
That immediately highlights the core paradox, doesn't it?
Yeah.
Benign by definition, yet potentially devastating in its local impact. It's certainly a condition that sounds like it could slip under the radar quite easily.
It does.
Okay, let's unpack this a bit more. Given its complex nature and that destructive potential you've outlined, who is most typically affected by PVNS? And just how prevalent is it, really? That rarity must contribute to the diagnostic delay you mentioned.
You've hit on a critical point there. Its rarity is indeed a major factor in the diagnostic puzzle. To put it into perspective, population-based incidence data, mainly from the U.S. actually, suggests it's truly uncommon. We're looking at approximately 9.2 new cases per million people diagnosed annually.
Per million per year. So really not common.
Not common at all. This low incidence means that for many clinicians, it's simply not a condition they encounter frequently. So naturally, it often gets overlooked in those initial differential diagnoses.
Makes sense. And the typical patient?
In terms of the patient profile, PVNS primarily affects young to middle-aged adults, typically those between, say, 20 and 50 years of age. There's a noticeable peak incidence observed in patients in their third and fourth decades.
Right.
So specifically between 30 and 40 years old.
Okay.
Now, whilst they can theoretically occur at any age, it is exceedingly rare in pediatric populations.
And that must cause issues.
It does, unfortunately. When it does present in children, it's often misdiagnosed for extended periods. Its presentation can be particularly atypical in younger patients, leading to delays in appropriate management and potentially more advanced disease by the time of diagnosis.
Right. What about gender? Is there a difference between men and women?
That's interesting, actually. The data offers a slightly mixed picture, which can add to the diagnostic ambiguity sometimes.
Oh.
Some large-scale epidemiological studies indicate an approximately equal incidence in men and women, suggesting no significant gender predisposition overall.
Oh.
However, other investigations, particularly those focusing on specific cohorts or perhaps the different forms of the disease, suggest a slight female predominance, especially, it seems, in the localized form of PVNS.
So maybe a slight leaning towards women, particularly for the localized type?
Possibly. It's a nuance clinicians might keep in mind, though it's certainly not a definitive diagnostic criterion.
Understood. You mentioned diagnostic delay earlier.
Yes, and perhaps one of the most clinically significant epidemiological features is its insidious onset.
Ah.
Patients frequently experience symptoms for a considerable period, sometimes years, before a definitive diagnosis is finally made.
Years.
It can be. The median time from the initial onset of symptoms to a confirmed diagnosis is often reported to be around 18 months,
18 months.
though it can certainly be longer in some cases. This prolonged diagnostic delay is a major contributor to the progressive joint damage we often see because the condition just continues its destructive process unchecked.
That really underscores why increased awareness is so important, doesn't it, for GPs and specialists alike?
Absolutely. Earlier identification and intervention are key.
18 months is a significant amount of time for a patient to endure unexplained pain and functional decline. That insidious onset, coupled with its rarity. Well, it certainly explains why it's such a diagnostic conundrum.
It is.
Now, here's where it gets really interesting for us clinicians. What do we currently understand about the underlying causes and the pathological processes that actually drive this condition? It sounds like there must be a specific biological engine behind this unusual overgrowth, something beyond just simple proliferation.
Indeed. Understanding the underlying pathophysiology is absolutely key to appreciating both its behavior and actually the rationale behind some of the emerging targeted therapies.
Right.
While the precise initiating cause of PVNS still largely remains unknown, our understanding of its genetic and molecular underpinnings has advanced dramatically in recent decades.
Okay, what have we found?
The most pivotal discovery, the one that's truly transformed our insights into PVNS, is the identification of specific genetic translocations.
Translocations.
Yes. In the overwhelming majority of PVNS cases, we find translocations involving chromosome 1p13.
Right, 1p13.
This particular genetic rearrangement leads directly to the overexpression of the gene encoding colony-stimulating factor 1, or CSF1, and importantly, its corresponding receptor, CSF1R.
CSF1 and its receptor, CSF1R.
Okay, this CSF1-CSF1R pathway is crucial. When CSF1 is overexpressed, it acts as a potent growth factor. It attracts and promotes the proliferation of various inflammatory cells, particularly macrophages and their precursors, which express the CSF1R on their surface.
So it draws in these cells?
Precisely. And what happens then is a fascinating but ultimately destructive cascade. This overexpression triggers the formation of aberrant cell clusters, essentially creating focal areas of soft tissue hyperplasia, specifically within the synovial lining cells. These cells, driven by the CSF1 signaling, then begin to form that characteristic thickened, overgrown synovial tissue we observe in PVNS.
That's the engine then?
That's the main engine, yes. Beyond the 1p13 translocation, other associated chromosomal abnormalities have also been identified, though less commonly. Things like a 5q33 rearrangement and even trisomies of chromosomes 7 and 5. These further suggest a complex genetic predisposition influencing the disease's development.
So it's complex genetically?
It is, but it's this fundamental dysregulation of the CSF1-CSF1R signaling pathway that directly underlies the locally aggressive, albeit technically benign, nature of the disease. It's what drives the uncontrolled synovial thickening and overgrowth.
And what does that look like under the microscope when you get a biopsy?
Yes. When we examine biopsy samples, the histological hallmarks are indeed quite distinctive. They tell a compelling story of the disease's activity.
Such as?
Microscopically, we observe a proliferation of rare polyhedral synovial-like cells. These are the main cellular component of the overgrown synovium. Crucially, there are abundant multinucleated giant cells, which are essentially fused macrophages. Now, these giant cells aren't specific only to PVNS, but seeing lots of them is a strong indicator of an active inflammatory or proliferative process.
Okay.
Perhaps the most pathognomonic feature, though, is the extensive hemosiderin deposition.
Hemosiderin, iron deposits.
Exactly. Hemosiderin is an iron storage complex, and these hemosiderin-laden macrophages, often described as pigmented foam cells, are what impart the characteristic brown, reddish, or sometimes even blackish coloration to the affected tissue.
Ah, the pigmented part of the name.
Precisely. This pigmentation is a direct visual indicator of recurrent, often subclinical, bleeding into the joint space. That's a hallmark of PVNS due to the fragility and high vascularity of the abnormal synovium.
Makes sense. What else do you see?
We also consistently see mononuclear stromal cells. These are actually thought to be the neoplastic cell population responsible for the CSF1 overexpression. The tissue typically forms highly vascular villi, sort of frond-like projections lined with plump, hyperplastic synovial cells. And frequently, common mitotic figures are observed, which confirms active cellular proliferation is occurring.
Is there an inflammatory component too, like arthritis?
Well, there's an intriguing hypothesis regarding an inflammatory component, yes. It draws some parallels with other chronic arthritic conditions, although it's certainly distinct from classical inflammatory arthropathies. Some studies have explored a potential link between prior joint injuries and the onset of PVNS.
Trauma.
Yes, suggesting that trauma might act as a trigger or perhaps a predisposing factor in genetically susceptible individuals. However, it's important for us to note that this correlation hasn't been consistently or definitively proven across all investigations. Many patients have absolutely no history of significant trauma.
So maybe a link, but not definite.
Exactly. Whilst an association is often reported in patient histories, a direct causative link remains largely unconfirmed.
That's a profound explanation, though, connecting the macroscopic presentation directly to that underlying genetic and cellular dysregulation. It's really clear that understanding this molecular engine of PVNS is vital, especially for developing targeted therapies.
Absolutely.
Now, you mentioned the local aggression, but it's not all uniform, is it? Can you delineate the critical differences between localized and diffuse PVNS? As I understand it, this distinction isn't just academic. It has pretty profound implications for both prognosis and the treatment strategies we choose.
You're absolutely right. The distinction between localized and diffuse forms of PDNS is not merely a classification, it's a fundamental determinant of clinical behavior, prognosis, and, most importantly, our therapeutic approach. This classification guides virtually every decision we make in patient management.
Okay, so let's start with localized.
Right. Localized PVNS. This is also frequently referred to as the nodular, or sometimes the classic form. As the name suggests, this variant is characterized by a more confined proliferation.
Contained.
Exactly. The tumor typically involves specific tendons supporting the joint, or it manifests as a well-circumscribed, often solitary nodule within just one area of the joint capsule or synovial lining.
What might you feel?
On physical examination, it can sometimes present as a palpable, firm nodule. It might appear skin-colored or perhaps slightly brownish. The most common site for localized PVNS, particularly within the knee, is the anterior compartment, specifically affecting the infrapatellar fat pad.
The fat pad below the kneecap.
Precisely. Up to 80% of localized knee cases originate there, which makes sense clinically, as the fat pad is a common site for synovial proliferation anyway.
And symptoms.
From a patient's perspective, localized PDNS is often slow-growing and, quite surprisingly, may be relatively painless in its early stages.
Really? Painless.
Relatively, yes. However, as it grows, it can certainly cause mechanical symptoms due to impingement within the joint. Things like locking, catching, or maybe giving way sensations, particularly during specific movements. The key clinical takeaway here is its well-defined nature.
And prognosis.
Prognostically, localized PVNS generally responds very well to surgical intervention. After a complete excision, which is typically done via arthroscopic synovectomy, the recurrence rate is commendably low, usually around 8%.
8%. That's pretty good.
It is, which makes it a much more manageable form of the disease.
Okay, so that's localized. What about diffuse?
Now, in stark contrast, we have diffuse PVNS. This form is significantly more widespread and, frankly, more aggressive.
How so?
It involves an entire joint with extensive, often global thickening of the joint lining. A critical characteristic is its frequent tendency for extra-articular extension.
Spreading outside the joint.
Exactly. This means the disease isn't confined to the joint capsule. It can extend significantly beyond, infiltrating surrounding soft tissues, musculature, even neurovascular structures. For example, in the knee, you might see extensive posterior extension outside the joint capsule, which makes surgical removal far more challenging.
Right.
On imaging, Diffuse PVNS is typically ill-defined or poorly circumscribed, reflecting its infiltrative nature.
And clinically,
Clinically, its behavior is considerably more aggressive than the localized form. Patients with diffuse PVNS invariably experience more severe, persistent pain and profound joint dysfunction. It leads to a much greater impact on their quality of life. This widespread and infiltrative nature makes it inherently more difficult to treat effectively.
any specific signs?
A frequent presentation, and indeed a diagnostic hallmark of diffuse PVNS, is its association with long-standing hemorrhagic joint effusions.
Bleeding into the joint.
Yes, recurrent, often spontaneous, bleeding into the joint space without a preceding traumatic event. Patients commonly present with painful masses, a markedly decreased range of motion due to the synovial thickening and the effusion and diffuse tenderness along the joint line. Recurrent atraumatic hemarthrosis is therefore a strong red flag for diffuse PVNS.
And the prognosis here? Much worse, I imagine.
Considerably less favorable, yes. Given its more aggressive nature and diffuse involvement, despite a thorough surgical synovectomy, the recurrence rate is significantly higher, ranging from approximately 30% up to 50%.
30 to 50% recurrence. That's high.
It poses a substantial challenge for long-term management and often necessitates multimodal or repeated interventions. This clear distinction is absolutely paramount for guiding our diagnostic investigations and, of course, our subsequent treatment algorithms.
That's a remarkably clear delineation, and it certainly drives home why accurate classification is so pivotal. With such varying presentations, though, and that insidious onset you've mentioned, how does a clinician typically encounter a patient with PVNS? What does that first presentation often look like?
Well, they usually present with joint pain.
Just pain.
Often, yes, insidious onset of joint pain. It can be quite variable from a mild sort of nagging discomfort to quite severe, poorly localized pain. This is often accompanied by a sense of stiffness, particularly after periods of rest, and noticeable swelling in the affected joint.
And the bleeding.
As we discussed, a crucial red flag, especially for the diffuse form, is that recurrent atraumatic hemarthrosis, spontaneous bleeding into the joint without any clear injury. Patients often describe the joint as filling up with blood.
What about function?
Functionally, patients may experience a progressive decrease in their range of motion. They might notice a palpable mass or a sort of fullness around the joint, and they frequently complain of mechanical symptoms, locking, catching, a sensation of the joint giving way under weight bearing.
Leading to limping.
In more advanced cases, yes. It can manifest as a noticeable limp or just general difficulty with activities requiring use of the affected limb.
And the trauma link.
It's interesting, as I mentioned, about 50% of patients might report a history of prior trauma to the affected joint. But the precise correlation remains inconsistent, so it shouldn't be relied upon as a primary diagnostic indicator.
Right. It sounds like it could mimic a lot of things.
Absolutely. The sheer diagnostic challenge here cannot be overstated. Because of its slow, progressive nature and these nonspecific symptoms, patients frequently undergo extensive workups for a whole myriad of other conditions first.
Like what?
Oh, inflammatory arthritides like rheumatoid arthritis, mechanical issues like displaced meniscal tears, infections like septic arthritis, even other benign masses such as ganglion cysts, schwannomas, or hemangiomas. PVNS is often way down the list initially.
Until other things are ruled out.
Often, yes.
And what would you find on examination?
During the physical examination, general inspection might reveal joint effusion, indicating fluid accumulation. Sometimes erythema, maybe if there's an inflammatory component or acute bleeding. Palpation of the joint often elicits tenderness along the joint line, and you might feel a palpable mass or just a diffuse boggy swelling. Limited range of motion, both active and passive, is a common and often quite profound finding.
Okay, so history and examination give clues. What's the comprehensive diagnostic pathway we should be pursuing then to actually nail the diagnosis, especially given that mimicry problem?
Right. For the diagnostic tools, we employ a multimodality approach. Imaging plays a pivotal role here.
Starting with X-rays.
Usually, yes. X-rays are typically the initial radiographic studies. Now, they might appear normal in early PVNS or in the localized forms, but they are essential for ruling out other pathologies and can provide clues in more advanced cases.
What sort of clues?
Characteristic findings, when they're present, include soft tissue swelling and specific bone changes. Cystic erosions, often with sclerotic margins, on both sides of the joint, sometimes called notching or pressure erosion. Or you might see frank bone destruction, sort of punched out lesions caused by the direct pressure and erosive activity of the proliferating tumor.
But X-rays aren't definitive.
No, definitely not. Magnetic resonance imaging, MRI, is unequivocally the most sensitive and indeed the gold standard imaging study for diagnosing PVNS.
Why MRI?
It provides unparalleled delineation of both the intra-articular, so within the joint, and any extra-articular disease extension. It shows you exactly where it is and how far it's spread.
What are the key findings on MRI?
Key findings include significant joint effusion, obviously, and that characteristic synovial expansion and thickening. But the critical MRI signature, the real giveaway, relates to the hemosiderin deposits.
The iron again.
Exactly. These iron deposits appear as low signal intensity on both T1 and T2 weighted images. And crucially, they produce a distinctive blooming artifact on gradient echo sequences.
Blooming artifact.
Yes, it's caused by the paramagnetic effect of the iron. It makes the dark areas appear much larger than they actually are on those specific sequences. This blooming artifact is highly suggestive, if not pathognomonic, of PVNS. It's a visual confirmation of that recurrent bleeding within the synovium.
Very characteristic then. Any role for CT?
Computed tomography, CT scans, are less sensitive for the soft tissue detail compared to MRI, but they are particularly useful for meticulously evaluating the extent of any cystic bone loss and osseous erosions. It gives excellent bone detail, better than MRI in that regard.
What about analyzing the joint fluid, arthrocentesis?
Yes, arthrocentesis, aspirating the joint fluid, is indicated for patients presenting with recurrent hemathroses. Analysis of the aspirated fluid typically reveals a grossly bloody effusion. It might appear dark brown or even blackish due to the breakdown products of hemoglobin over time.
And the final confirmation.
The definitive diagnosis is typically achieved through diagnostic arthroscopy combined with synovial biopsy.
Looking inside the joint.
Exactly. Arthroscopy allows for direct visualization. The clinician will typically observe the characteristic brownish or reddish, inflamed synovium, often with its distinctive frond-like papillary projections, or villi.
And then you take a piece.
Precisely. A synovial biopsy taken during the procedure is then crucial for microscopic confirmation. Histopathological examination reveals those pathognomonic, hemosiderin-stained multinucleated giant cells, along with the pigmented foam cells, the mononuclear stromal cells, and evidence of active cellular proliferation with those mitotic figures we talked about.
So biopsy confirms it. Any blood tests?
It's worth noting that routine laboratory tests, things like C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, which are markers of systemic inflammation, are often completely normal in PVNS patients, despite the visible soft tissue swelling and the local inflammatory processes happening in the joint.
So normal inflammatory markers can be misleading.
They can, unfortunately. It can contribute to the delayed diagnosis by steering clinicians away from inflammatory causes when these markers are within normal limits.
That comprehensive diagnostic pathway truly underscores the complexity. Okay, so once we've navigated that labyrinth and finally confirmed a diagnosis, what are the established and indeed the emerging strategies for managing PVNS, especially given its relentless tendency for local aggression and that high recurrence rate? It sounds like a multi-pronged approach is often necessary.
You're absolutely right. A multimodal approach is essential because PVNS is fundamentally a locally destructive process. It actively invades and destroys healthy bone and cartilage and can grow to a significant size. Therefore, conservative management alone is generally ineffective and not recommended.
So surgery is key.
The cornerstone of treatment primarily involves surgical intervention, yes, to meticulously remove the tumor and the affected joint lining. The overarching goal is to achieve a maximal, if not complete, marginal excision of the diseased tissue.
Okay. Tell us about the surgical procedures.
Right. Surgical procedures remain the gold standard. For synovectomy, which is removal of the synovium, we differentiate based on the extent of the disease.
Localized versus diffuse again.
Exactly. Partial synovectomy is typically reserved for localized PVNS. This can often be performed arthroscopically, particularly for well-defined lesions in accessible areas like the anterior knee. Arthroscopic approaches offer significant advantages for the patient.
Such as?
Improved functional outcomes, better preservation of joint range of motion, and a much quicker recovery time compared to open surgery.
Makes sense. And for diffuse?
Well, for grossly symptomatic and painful diffuse PVNS, a total synovectomy is indicated. The aim here is the most complete possible removal of the entire joint lining.
That sounds much more extensive.
It often necessitates a fully open surgical approach, especially for extensive diffuse disease that involves both the front and back of the knee, for instance, to ensure a thorough excision of all affected tissue. In some complex cases, a combined approach might be employed, perhaps open for the posterior knee arthroscopic for the anterior, which can help to decrease the overall surgical invasiveness and potentially aid in patient recovery.
What if a tendon is damaged?
Ah, yes. If localized PVNS has caused damage to an adjacent tendon, for example, surgical repair would be undertaken concurrently during the tumor excision.
And what if the joint is already severely damaged?
Yes, for patients presenting with advanced disease and extensive joint destruction, more radical options become necessary.
Like joint replacement.
Total joint arthroplasty, replacement, yes. A total knee, hip, or shoulder replacement may be required to relieve intractable pain and significantly improve function. However, it's critical for clinicians and surgeons to be aware that these procedures in PVNS patients are associated with higher rates of postoperative stiffness, heterotopic ossification, and even infection compared to standard indications like osteoarthritis.
So higher risks.
Definitely requires meticulous preoperative planning and postoperative care.
Any other options for advanced disease?
In severe end-stage cases, particularly involving joints like the ankle and arthrodesis or joint fusion, might be the only viable option to achieve pain relief and stability, albeit at the cost of mobility, of course.
Okay, so surgery is central. What about other treatments? Radiation.
Yes, beyond surgery, radiation therapy plays a crucial adjuvant role, particularly for widespread diffuse PVNS, or in cases where surgical resection has been incomplete or unsuccessful.
How does it help?
Radiation can effectively shrink residual tumor burden and significantly reduce the likelihood of recurrence.
What kind of radiation?
Historically, external beam radiation was widely used. Typical doses were around 30-35 gray in 15 fractions, or perhaps up to 50 gray in 25 fractions. While it's effective, this approach carried potential complications: skin necrosis, joint fibrosis, and in rare instances, radiation-induced sarcoma years later.
Are there newer methods?
Yes, a newer, often preferred method is intra-articular radiation synovectomy. This involves injecting a radioactive colloid directly into the joint space. It offers more localized treatment and generally fewer systemic side effects.
And does combining surgery and radiation help?
Crucially, yes. Contemporary evidence clearly demonstrates that when radiation therapy is combined with a total surgical synovectomy, it significantly reduces the recurrence rate of diffuse PVNS. It can bring it down to a more manageable range of approximately 10–20%.
10 to 20%, down from 30 to 50, that's a big difference.
It is. This combination therapy has become a standard of care for extensive or recurrent disease.
Any caveats? Children.
Yes, a very important point. It's important to underscore that radiation is generally avoided in pediatric patients. This is due to the significant potential for growth plate damage, limb length discrepancies, and other serious long-term medical issues associated with radiation exposure in developing tissues.
Right. Now, what about drug therapies? You mentioned targeted treatments earlier.
Yes, perhaps one of the most exciting and rapidly advancing areas is in emerging drug therapies, specifically molecular therapeutics. These treatments represent a real paradigm shift, moving towards medications that specifically target those identified molecular drivers of PVNS, particularly the CSF1R protein we discussed earlier.
The receptor pathway.
Exactly. Pexidartinib is a leading example here. It was approved by the FDA back in August 2019. It's an oral CSF1R inhibitor indicated for adult patients with symptomatic tenosynovial giant cell tumor, which includes PVNS, that's associated with severe morbidity or functional limitations, and is not amenable to improvement with surgery.
How effective is it?
In clinical trials, this oral medication, typically taken once daily for 24 weeks, has demonstrated significant improvement in the PVNS disease burden in approximately 40% of patients. It leads to substantial tumor shrinkage and symptom alleviation. It's really been a game changer for those with extensive, surgically complex, or recurrent disease.
40% response is significant. Are there others in development?
Yes, other promising agents are also under investigation. Imacuzumab is a monoclonal antibody that directly targets CSF1R, effectively blocking the signaling pathway. PLX3397 is another oral tyrosine kinase inhibitor that, similar to pexidartinib, also inhibits CSF1R. Both of these agents have shown objective clinical responses in early-phase trials, further underscoring the validity of targeting the CSF1 pathway.
And combination therapies.
Current research is also vigorously exploring combination therapies. For instance, combining CSF1R inhibitors with other targeted agents, perhaps anti-PD-L1 immunotherapy, or PA3-Caradact pathway inhibitors like LY294002, holds significant promise.
Why combine them?
The rationale here is to potentially enhance response rates, maybe overcome resistance mechanisms that might develop, and improve the durability of the treatment. Ultimately, the aim is to further improve long-term outcomes and potentially reduce the need for repeat surgeries or the progression to end-stage joint destruction. This multimodal and increasingly targeted approach is truly defining the contemporary management of PVNS.
It's clear that the treatment landscape for PVNS is evolving incredibly rapidly, offering a much more diverse arsenal than ever before. It's quite hopeful.
It is.
But beyond the immediate intervention, whatever it may be, what does the recovery process typically look like for a patient who has undergone these treatments? And crucially, what are the potential pitfalls and complications that we as clinicians, and indeed our patients, need to be acutely aware of, particularly that notorious issue of recurrence?
Recovery from PVNS treatment, especially surgical intervention, is definitely a journey. It requires significant patient commitment and meticulous clinical oversight. And yes, vigilance for potential complications is key. Rehabilitation is absolutely paramount post-surgery.
Physical therapy.
Exactly. To ensure patients regain as much strength and range of motion as possible. That directly correlates with their long-term functional outcome.
Does it differ based on the type of surgery?
Yes, significantly. For those undergoing arthroscopic surgery, typically for localized PDNS, the recovery is generally quicker and less arduous. It usually requires a focused, shorter course of physical therapy. This often allows for a relatively swift return to normal daily activities.
And open surgery.
However, open surgical procedures, particularly those extensive total synovectomies for diffuse PVNS, are far more invasive. These carry a significantly increased risk of post-operative stiffness and scar tissue formation.
Meaning longer rehab.
Yes, necessitating a much more regimented and prolonged physical therapy program, often spanning several months, to really optimize joint mobility and overall function.
Okay. Now, about those complications, recurrence is the big one.
It is. The most frequent and indeed the most challenging complication is recurrence. While localized PVNS rarely recurs after complete surgical excision, the diffuse form, as we've said, has a notoriously high recurrence rate.
Even after apparently complete surgery.
Yes. Despite what might be considered a complete synovectomy, recurrence rates can range from 10% to as high as 50%.
Why so high?
It's often attributed to the inherent difficulty in achieving a truly complete excision, simply due to the infiltrative nature of diffuse disease. Microscopic remnants of the abnormal synovium can persist and lead to subsequent regrowth.
And how do we mitigate that?
As we touched upon, one of the most effective strategies is combining surgery with adjuvant external beam radiation therapy. That can significantly reduce recurrence rates down to that more manageable 10–20% range for diffuse PVNS.
Right. What other complications should we be aware of?
Beyond recurrence, several other complications can arise. If PVNS is left untreated, or if it progresses despite therapy, it inevitably leads to moderate to severe joint deformity, progressive degenerative articular changes, and ultimately debilitating osteoarthritis.
Leading to fusion or replacement anyway.
Exactly. In the most severe and intractable cases, the relentless cortical bone destruction and joint damage may necessitate more extreme interventions like arthrodesis, or, in exceptionally rare and desperate circumstances, even amputation of the affected limb.
Gosh, and risks from the treatments themselves.
Yes, there are specific treatment-related risks that we must carefully consider and discuss with patients. For patients receiving pexidartinib, the primary and most serious risk is hepatic toxicity. Liver problems.
Oh, serious.
It can range from transient elevation of liver enzymes to severe and potentially fatal liver injury. This necessitates close and vigilant monitoring of liver function tests, specifically AST and ALT, throughout the treatment course.
Any other side effects of pexidartinib?
Hair depigmentation is another commonly noted, though obviously less serious, side effect.
Okay, and surgical risks.
Surgical approaches also carry their own set of risks, of course. Open surgeries, by their nature, are associated with longer hospital stays, increased post-operative pain, and more prolonged rehabilitation periods. For instance, extensive posterior approaches to the knee, while sometimes unavoidable for diffuse disease, place critical neurovascular structures like the popliteal artery and nerve at risk.
And arthroscopy, less risky.
Less invasive, yes, but it demands considerable technical expertise, and it may be less effective for very large masses or those with significant local tissue invasion. Making a truly complete excision challenging arthroscopically can potentially lead to higher recurrence rates if not performed meticulously.
And radiation risks.
Radiation therapy, while effective in reducing recurrence, carries risks including local skin changes, fibrosis, and in extremely rare cases, the induction of a secondary radiation-induced sarcoma many years post-treatment.
Finally, what about spread? Metastasis.
Right. While PVNS is overwhelmingly a localized disease, it is important to acknowledge that there have been exceedingly rare documented instances of metastasis to distant sites, lungs, muscles, regional lymph nodes,
But very rare.
exceptionally rare. And it's absolutely crucial to emphasize that this is far more commonly associated with the truly malignant forms of tenosynovial giant cell tumors, rather than the typically benign, albeit locally aggressive, PVNS we're mostly discussing. That distinction is very important for patient counseling and prognostication.
That's a comprehensive and frankly quite sobering overview of the challenges in recovery and the potential complications. It truly reinforces the need for ongoing vigilance and careful management.
It does.
Despite these hurdles, what's the long-term outlook generally for patients diagnosed with PVNS? And perhaps more optimistically, what exciting avenues are researchers currently exploring to improve patient care and those long-term outcomes?
Well, the prognosis for PVNS, from a life expectancy perspective, is generally good. It's rarely a fatal disease.
That's reassuring.
It is. However, its primary impact is really on the patient's quality of life. It's a condition that relentlessly erodes joint function, leading to chronic pain, reduced mobility, and considerable difficulty with daily activities.
So function is the main issue.
Primarily, yes. The long-term outlook for functional preservation ultimately hinges on several intertwined factors: the initial size and anatomical location of the tumor, the extent of its spread, localized versus diffuse, and most critically, the timeliness and efficacy of the chosen treatment.
And recurrence plays a big role.
Absolutely. While surgical cure is certainly achievable, particularly for the localized form, the persistent high recurrence rate of diffuse PVNS means that accelerated degenerative changes within the joint are a common long-term reality. This often leads to the eventual need for a total joint arthroplasty to manage pain and restore some semblance of function.
And you mentioned replacements in PVNS patients have unique issues.
Yes, it's vital for orthopedic surgeons to be aware that total knee arthroplasty, for example, when performed in patients with a history of PVNS, is indeed associated with its own unique set of complication rates, often higher rates of stiffness, infection, and even recurrence of PVNS around the prosthesis, compared to standard osteoarthritis indications. This necessitates specific surgical considerations and thorough patient counseling.
Right. Looking to the future, then, what's happening in research?
The landscape of PVNS research is incredibly vibrant and advancing at a rapid pace. This is largely driven by the identification of those key genetic and molecular factors, particularly the CSF1R pathway.
Beyond CSF1R.
Researchers are actively investigating novel molecular targets beyond just CSF1R. For instance, factors like PLIN, PPPK2A, and TYRO-BP have been identified as potentially playing roles in the disease's pathogenesis. Understanding their specific involvement could unlock entirely new diagnostic biomarkers and, more importantly, innovative therapeutic strategies targeting different pathways. That could potentially improve patient outcomes even further.
And improving current therapies.
Yes, a significant area of focus is also on optimizing existing therapies. There are extensive ongoing efforts to refine the use of targeted molecular therapies, like peximartinib and other CSF1R inhibitors.
Ow.
This includes exploring optimal dosing regimens, duration of treatment, and identifying patient subgroups who might respond best, or conversely, those likely to develop resistance. Furthermore, there's considerable research into various combination approaches.
We talked about that.
Exactly. Combining anti-PD-L1 immunotherapy with CSF1R inhibitors or integrating PI3K-ACT pathway inhibitors, the rationale is that by hitting multiple targets or modulating the tumor microenvironment, we can enhance the efficacy of treatment, potentially overcome resistance, and more effectively slow down disease progression, ultimately aiming to reduce joint deterioration and profoundly alleviate symptoms for longer.
That sounds promising. Are there challenges in the research itself?
There are. It's crucial to acknowledge the research challenges that persist in a rare disease like PVNS. Many existing studies, particularly those investigating novel therapies, often involve relatively small sample sizes simply due to the low incidence, and sometimes they have shorter follow-up durations.
So we need bigger, longer studies.
Exactly. This highlights a clear and pressing need for larger, multi-center international trials with extended follow-up periods. Such robust trials are essential to rigorously validate current findings, to fully unravel the complex genetic heterogeneity of PVNS, and to comprehensively assess the long-term efficacy and safety profiles of these newer, targeted treatments in diverse patient populations.
But overall, there's hope.
Definitely. The evolving landscape of PVNS management offers significant hope, particularly through these molecular breakthroughs, for dramatically improving the long-term quality of life and functional prognosis for our patients.
That vision for the future certainly offers a great deal of hope. And given the really multifaceted nature of this condition, from the delayed diagnosis right through to complex treatment and long-term management, it truly sounds like a condition that benefits immensely from a properly joined-up approach.
Absolutely.
What, then, is the best way for healthcare professionals across different specialties to collaborate effectively for optimal patient outcomes in PVNS, integrating all these various facets of care we've discussed?
You've highlighted perhaps the most critical element for achieving the best possible outcomes in PVNS, a comprehensive, interprofessional team approach. This model goes beyond simply referring a patient between specialists. It really integrates individual patient goals, establishes realistic functional outcomes, and ensures a truly coordinated care pathway across multiple disciplines.
Where does that collaboration start? Diagnosis.
Firstly, yes, the diagnosis is optimally established through the collaborative effort of the primary care physician, who often first raises the suspicion alongside radiologists, providing those critical imaging insights, and pathologists who give the definitive microscopic confirmation from biopsy. This upfront, coordinated collaboration ensures the correct imaging studies are ordered and interpreted accurately, leading to informed decisions about the need for biopsy. It minimizes diagnostic delays and ensures the patient gets onto the correct treatment pathway as early as possible.
And once diagnosed.
Once a diagnosis is confirmed, multidisciplinary treatment planning becomes paramount. The core care team typically includes orthopedic surgeons, oncologists, especially if systemic therapy or radiation is being considered, and clinical pharmacists.
How should they work together?
These professionals should engage in open, transparent discussions with the patient, collaboratively establishing patient care goals, and meticulously weighing the risks versus benefits of surgical intervention versus systemic treatments. For example, considering an oral medication like pexidartinib for extensive diffuse disease, where surgery is unlikely to succeed without prohibitive morbidity, particularly in patients without major hepatic comorbidities, that's a decision best made collectively after a thorough case discussion involving everyone.
The pharmacist's role.
The pharmacy team plays a vital, often understated role in medical treatment, meticulously verifying dosing, ensuring proper administration, diligently checking for potential drug interactions or contraindications, especially crucial with these novel molecular therapies.
And nursing and therapy support.
Throughout the entire diagnostic, treatment, and postoperative phases, nursing staff with specialist training in orthopedics and surgical care provide crucial patient support, continuous evaluation, and tailored counseling. If surgery is the chosen path, physical therapists are absolutely indispensable for guiding the rehabilitation process, helping patients regain function, restore range of motion, and rebuild muscle strength. And the effective management of pain, which can be a common and persistent symptom, should actively involve the pharmacist to ensure effective and safe analgesic strategies are implemented, considering the potential for chronic pain.
So it's a whole team effort.
Absolutely. By embracing this interprofessional team paradigm where all these disciplines collaborate seamlessly, we can ensure the most comprehensive and effective patient outcomes, regardless of the specific management pathway chosen.
Anything else?
And I must underscore a crucial, often underutilized element in this collaborative framework: patient empowerment.
Involving the patient more.
Actively increasing the patient's role in constructing their collaborative treatment plan is not only ethically sound, but is also empirically proven to solidify patient compliance and significantly improve long-term outcomes, not just in PVNS, but across the entire spectrum of complex diseases. Continued patient-physician collaboration, right from the initial diagnosis through treatment and ongoing long-term management, is unequivocally advised for this challenging condition.
That's a fantastic point to end on the power of the informed, engaged patient within that collaborative team. What an extraordinary, albeit challenging, journey we've taken into the world of pigmented villonodular synovitis today. We've certainly had a truly comprehensive exploration, haven't we? Covering everything from its rare incidence and the complex pathophysiology driven by that CSF1R pathway, right through to its varied and often deceiving clinical presentations and the cutting-edge multimodal treatments now available.
Yes, we've covered a lot of ground.
The profound importance of an integrated multidisciplinary approach and genuine patient involvement truly shines through as the cornerstone of effective management. Ultimately, understanding PVNS isn't just about dissecting its intricate biology, is it? It's about appreciating the nuanced and often protracted patient journey and that relentless pursuit of better quality of life in the face of a persistent, locally aggressive disease.
Well said.
If you found this deep dive insightful, please do consider rating and sharing the deep dive with a colleague who might also benefit from these insights. Thank you so much for joining us and sharing your invaluable expertise today.
It's been my pleasure. It's certainly a field experiencing rapid advancements, particularly with these molecular therapies, and staying abreast of these developments truly offers significant hope for revolutionizing long-term outcomes for our patients.